Hi, everybody, and welcome to the last section of our 10-part GI lecture series. For those of you studying for USMLE Step 1 or COMLEX Level 1, today we're going to talk about the liver. And just full disclosure, this is going to be the longest section by far, so keep that in mind as you're studying. But let's get a move on with it. We'll start with anatomy like we always do. And for anatomy, there's a few different things we need to discuss for the liver. So we'll start with blood supply and some of the associated conditions that you have to recognize. The first thing you have to remember is that the liver receives blood through two different sources, and these are both part of our portal triad. It can receive it through the proper hepatic artery, and it could also receive the excess blood that comes through the portal venous system. So let's look at the proper hepatic artery first. So how that works is the blood will flow from the aorta. Because we're talking about a foregut organ, the liver, it'll go through the celiac trunk into the common hepatic artery, then to the proper hepatic, and finally into the liver. If we look at a pictorial representation of this, we have our aorta, and then it'll go to the celiac trunk, which is this area with all three branch points. And then it'll go through the common hepatic artery, proper hepatic, and the blood will finally reach the liver. In addition to receiving blood through the proper hepatic artery, the liver also receives blood supply from the portal vein. And most of our GI tract actually drains into the portal system. So this blood should be deoxygenated. It has a lot of nutrients and other supplements that were absorbed in our GI tract as well. So if you think about it, you don't want all of that stuff instantly entering the systemic circulation without any sort of checkpoint. So the liver kind of acts at that as that checkpoint and can metabolize certain substances prior to them entering systemic circulation and potentially causing some damage. How this works, you'll have your portal vein draining into the liver itself, and then within the liver, that'll drain to the hepatic vein, and from the hepatic vein, it'll reach the inferior vena cava, which is our main vein that brings blood back to the heart. And we'll show this pathway a number of times as this lecture moves forward today. And you can see the portal system, it's draining venous blood this way and all the way up into the liver. And we can show it in a little bit of a different way. If we have our blood supply flowing from left to right, you have your portal vein, liver, hepatic vein, and IVC. And I like showing it in this diagram because we can start talking about some of the clinical conditions and the subsequent effects of those conditions. So here's some relevant conditions. We're going to talk about the first three conditions right now because it relates most to this blood supply. I will mention portal hypertension much later. I go into great detail about portal hypertension and all of the sequelae of portal hypertension when we talk about the liver cirrhosis later on in the condition section. So keep that in mind. We'll start with Budd-Chiari syndrome though. So Budd-Chiari syndrome is a thrombosis of the hepatic vein. So if we go back to our diagram, it's going to be a thrombus forming in this region here. And this is a very rare case. It happens in about 1 out of every million people. And it's going to be associated with people who are hypercoagulable already, which makes some sense if it's a thrombosis. Your symptoms you're going to get, there's something that you really have to know. This applies to both Budd-Chiari syndrome and right heart failure. You're going to get something called a nutmeg liver, sometimes called congestive hepatopathy. And you can also find that if somebody has Budd-Chiari syndrome, they're going to be in severe abdominal pain. Their liver can be very, very enlarged. They could have ascites, which is like fluid in your cavity. And all of this is caused by a backflow of fluid. So let me show what I mean by that. What's going to happen is that if you have this thrombus here, you're going to have your blood supply trying to get past this thrombus, but since it can't, everything's going to build up and you're going to get fluid that's just stuck behind it. So you'll get liver congestion. You also get portal venous congestion as well. This is a picture of what a nutmeg liver looks like. On the top right is a picture of an actual nutmeg. And you can see some of the similarities here. And this is a hallmark of congestive liver disease. So if your liver is congested in the sense that it has a lot of fluid that's backed up in that area, it'll look kind of like this. And you can see the similarities between the two. And this can be caused by only a couple things. Right heart failure is the most common cause of nutmeg liver. And obviously, Chiari syndrome, as we just talked about, can also cause it. Something I want to talk about is how do we tell the difference? Let's say we have a patient who has congestive hepatopathy, and we haven't like done an echocardiogram or done anything like that to measure pressures as well. How can we tell Chiari from right heart failure on a question stem, especially? So what can happen here is that in Chiari syndrome, you don't get something called jugular venous distension or JVD. So jugular venous distension, as the name suggests, is distension of your jugular veins. And that's going to happen when any of your veins are congested. Um, your IVC is one of your main veins as well. So if your IVC gets congested, it's likely that your jugular veins will also get congested. It's because that. So let me show you what I mean. In this case, in Chiari syndrome, notice how our IVC is distal to the thrombosis. So because there's nothing actually making it to the IVC, there's not going to be any jugular venous distension. Let's contrast that with right heart failure. So remember that our IVC is the main, this and the SVC are the main veins that drain blood back to our heart. So here's a picture of our heart here. Let's imagine that our heart's not working at all. So if our heart's not working, then fluid will back up proximal to that as well. So in addition to liver congestion and portal venous congestion, you're going to get congestion of your hepatic vein, congestion of your IVC, and congestion of your jugular veins. And because of that, this congestion here, you will see jugular venous distension in right heart failure. So on question stems, keep a lookout for that. If they mention any sort of JVD, which is like pulsating, you can see congestion in the neck essentially. And they'll just usually on a question stem tell you yes or no if they have JVD. Another thing I want to talk about, now that we've talked about Chiari syndrome and right heart failure, I want to discuss portal vein thrombosis. So imagine if you have a thrombus in this region here, it's only going to cause portal vein hypertension and congestion. So as you can see, if nothing's coming through, you're going to get a lot of backflow in the portal system directly. But it's important to realize that the liver is unaffected. There's no congestive hepatopathy. So again, that's another differentiating factor if they ask you on a question stem, basically saying that somebody's got all these problems. Maybe they have ascites and portal hypertension, and you're trying to figure out what's going on, and you realize their liver is completely normal. I want you to at least consider portal vein thrombosis as a potential cause. Now let's talk about the portal triad, which we've discussed in previous lectures. This is located within the lesser omentum, located here, and it courses through what's known as the hepatoduodenal ligament, which connects as the name suggests, connects the liver and the duodenum. There's three structures you need to be aware of: the proper hepatic artery, the portal veins, and the common bile duct. So the Pringle maneuver, which we discussed in the small intestine lecture as well, is a maneuver that some surgeons can do if they notice abdominal bleeding, especially if the bleeding seems to originate from the liver. The Pringle maneuver can help determine whether this is due to one of the vessels in the portal triad, or if it's due to something like the hepatic vein or the IVC instead. So you can clamp the hepatoduodenal ligament, and what that'll do is it'll clamp blood flow to the portal triad, which we just discussed consists of the proper hepatic artery, the portal vein, and the CBD. So I'm going to draw our framework that we just used for Chiari syndrome and right heart failure and portal vein thrombosis. But I just want to remind us that in addition to the portal vein draining to the liver, we also have the hepatic artery. So it receives through these two sources. But keep in mind that if there's a liver bleed, it doesn't necessarily mean it has to come from these two sources. it could actually be originating more distally in the hepatic vein or the IVC. So what the the Pringle maneuver will do is it'll block flow to the portal vein and hepatic artery. And if you notice that there's still continued bleeding after using the Pringle maneuver, that might make you consider the hepatic vein or the IVC as sources instead, because there's still continued bleeding. However, if bleeding does stop after you've clamped the triad, now you're more concerned that it is a portal vein or a hepatic artery bleed. And on question stems, they really like you to they really keep it simple as far as differentiating between these bleeds. What they'll do is they'll give you, if it's a pulsating, bounding bleed that stops, that sounds more arterial in nature. And so if you see that on a question stem, you should probably pick something related to the hepatic artery. On the other hand, if it's more of a gradual oozing bleed that stops after you perform a Pringle maneuver, then that makes it more likely that they want you to pick a portal vein as the cause of the bleed. Okay, so now let's discuss the liver lobules and zones. And this is a good segue because the portal triad is very anatomically associated with the liver lobule. So remember that the liver receives blood supply through both the portal vein and hepatic artery. So how does that actually work in practice? Well, what happens is that the liver is set up in a way where you have countless lobules. And portal triads will border each of these lobules. So on the top right of your screen, you can see a portal triad. And what happens here is you have your common bile duct, you'll have your hepatic artery located here, and you'll have your portal vein. So the portal triad has now entered the liver, but now how does the blood actually flow through the liver? So what happens here is that we have a central vein, which I've highlighted in red at the center of each of these lobules. And blood will drain from that portal triad and percolate until it reaches the central vein. So you can see that both the arterial and the venous blood both will drain in this manner. And on the other hand, the common bile duct is actually receiving bile that's made in the liver, and this will ultimately flow down your biliary tract into your right and left hepatic ducts, your common hepatic duct, into your cystic duct, and into the gallbladder, and then it'll get excreted later on into your duodenum. Another thing I want you to recognize is the three zones of the liver. So the first zone it's named in the order in which portal fluid would reach the liver, essentially. So the one that's closest to the portal triad, basically the first one that the portal triad would ever encounter, is zone 1, sometimes called the periportal zone. Zone 2 is in the middle, it's called the intermediate zone. And then zone 3, sometimes known as the centrilobular zone because it's in the center of the lobule, that's the zone right here that's closest to the central vein. And so now I'm going to draw this in a pictorial format because sometimes seeing everything on a histology slide can be a little confusing, at least for me. Here I've drawn our portal triad and I've drawn our central vein. And remember that the blood flows from the portal triad into that central vein and the bile flows in the opposite direction. Now, this isn't the only portal triad and central vein in our liver. In fact, it's not even the only relationship in one hepatic lobule. What we'll find is that each lobule has one central vein, but it is surrounded by many portal triads. And these all are draining bile out into the portal triad and blood into that central vein. And keep in mind, we still have our 3 liver zones that I just want to mention. We have our periportal zone, which is closest to the portal triad. This is our most oxygenated zone, which should make some sense because our hepatic arterial blood has this is the first zone it encounters. And so as that arterial blood sifts through here, it's going to be high in oxygen in this early segment. So it'll be resistant to ischemia. If you ever have ischemia, we're going to find out later that like if you have shock liver, ischemic hepatitis, it's not going to damage zone 1. It'll most likely damage zone 3. This is the closest zone to incoming portal venous blood as well, as we know. And the relevance of that, recall that our portal vein system, it's not your normal vein system where it just goes through a capillary and then it goes to a vein. Really, the whole point of the portal vein system is to filter out any toxins that might have been in the GI tract that our GI tract accidentally absorbed, right? Our liver is more of a checkpoint just to make sure that anything that the GI tract absorbed is okay and safe, or it gets neutralized before it can enter our systemic circulation. The downside to that is that if there are toxins or viruses or what have you in our portal system, the first thing that's going to get affected is zone 1 and most likely to get damaged. Zone 2 is the intermediate zone. It doesn't really have too much clinical significance. I've heard a lot of not question banks, but I've seen a lot of resources that always mention that it gets damaged in yellow fever, and then they have this mnemonic where the two L's in yellow is like zone 2, essentially. I've never been tested on this, and I don't remember seeing any questions bank even practice questions on this, but something to keep in mind. Zone 3 is much more high yield than Zone 2, and so we'll go over what Zone 3 is all about, the centrilobular zone, highlighted in yellow here. So this is the least oxygenated zone, which should make some sense because the hepatic artery has a lot of oxygen here, but as oxygen gets utilized by cells, there's going to be less available in this region. And so this is the most susceptible to ischemia. This has the highest concentration of cytochrome P450 enzymes. Remember that these enzymes are responsible for neutralizing and metabolizing a lot of products, including many of the drugs that people take. So here's a few enzymes. The downside to being the source for neutralizing all these toxins is that they're the most sensitive to damage from these toxins because they're interacting with them so much. So this region is at higher risk. This region also has the highest proportion of mitochondria in it. And because of that, you can see if there's ever toxins that specifically attack mitochondria, such as alcohol is a really good example, you'll see a lot of the effects in zone 3 first. So if you imagine if these purple things are our mitochondria and we have a lot of alcohol in our system, what can happen is that these mitochondria can die off and fat can start to deposit. And when we discuss alcoholic liver disease, I'll mention again that the fatty deposition typically occurs in zone 3 here, the centrilobular zone. This is the zone that's closest to the hepatic vein, which if you remember our framework of portal vein to liver to to hepatic vein and then into the IVC, it makes some intuitive sense that the central vein is the closest to the hepatic vein. What that means though is that if there is a congestion, let's say there's a backup of fluid, the first thing that's going to be congested would be zone 3 and then zone 2 and then zone 1 in that order. So this will get congested right here. And here's another picture of that. Here's our hepatic vein in IVC. If the liver ever gets congested, zone 3, it will be the first affected. There's only, I believe, 2 cell types that really matter in the liver that they're going to test you on at least. I shouldn't say there's only 2 that matter. But the 2 that you should know for step 1 or level 1 at least are the Kupffer cells and the stellate or Edo cells. So the Kupffer cells are a specialized type of macrophages that exist in the liver, and they help clear bacteria and damaged red blood cells. And I like to remember Kupffer cells by copper cells. I think they're kind of the cops. They try to restore order. They're the macrophages that are trying to make sure everything's on the up and up. Stellate or Edo cells are probably the most high yield cell you have to know in the liver. When they're not doing anything, where they're kind of inactivated in their dormant phase, they help store vitamin A, but their real function or their real clinical relevant for our purposes is that when these stellate cells or Edo cells become activated, they like to secrete a compound called TGF beta. And TGF beta is known to cause fibrosis. So this can lead to hepatic fibrosis, which can in turn lead to cirrhosis and all of the complications associated with cirrhosis. So sometimes they'll give you this convoluted question where by the end of the question, you find out that the person has cirrhosis, and then they'll ask you the activation of which cell may have contributed to this pathogenesis. And the answer might be like the stellate cell. So that's it for anatomy. Let's move on to physiology. What does the liver actually do? And we'll also talk about some of the tests that you can perform, the laboratory studies you can perform to evaluate liver function. So liver function, the liver does so many things. So it is important I tried to break this down to make it a little bit easier to understand all of the things. So we're going to talk about all of the important things that the liver produces, as well as all of the things that the liver metabolizes. So it produces bile. We'll start with that. And from our hepatobiliary and I believe our pancreas lecture, we talked about the function of bile. So bile has four main functions. It's used for digesting fats, excretion of waste products. It can provide an alkaline fluid to counteract stomach acid. And bile also has bactericidal activity against microorganisms. And if you wanted to hear more about the functions of bile, please check out the hepatobiliary lecture where I go into great detail in the physiology section as well. So here, for the bile liver function, I'm just going to remove the artery and vein for a moment just so you can see that bile is flowing from this central vein out into the portal triad. So what that looks like is that the liver's creating bile, it's sending it out that central vein into the portal triad, into these ducts ultimately to be stored in the gallbladder. From there, when the gallbladder contracts, all that bile flows down and into our duodenum, and that can help with fat absorption. The liver produces a number of proteins, and this isn't even going to scratch the surface, but I wanted to let you know a few of the proteins so you're aware of that. So albumin is the most important one. 50% of the proteins in plasma that we have are albumin. And what it does, albumin's really useful because for a few things. So it binds several different drugs, cations, fatty acids. So it's a really good carrier protein, and it binds certain substances that are floating in our plasma. But the most important thing that you need to recognize for step one is what albumin does regarding maintaining fluid within our intravascular space. So let's talk a little bit about hydrostatic and oncotic pressure. So here, right now at the bottom here, before I actually show this, we have an arterial, we have our capillary, and we have our venule. And obviously these exist throughout our body. This is how we need the capillaries in order to perform gas exchange between O2 and CO2. So in a normal, any vessel that you look at in our body, you're going to have some fluid that's already in our intravascular space, and you'll have a bunch of proteins as well. And what's going to happen is that there are two competing forces that are fighting against each other to keep this fluid either within the space or to make it leave the space. So the first force that you should recognize is the hydrostatic pressure. So there's always pressure on this fluid to get pushed out. There's always the intrinsic pressure of all that fluid inside this contained space, and it kind of wants to escape. But that is usually balanced by the oncotic pressure, and the oncotic pressure is the pressure of these proteins to draw water back into the system. So you have this hydrostatic pressure pushing fluid out, and the oncotic pressure pulling fluid back in. And normally what happens is that in your arterioles, there's a relatively higher pressure in your arterioles than in your venules. And so this will actually drive a little bit of water outside into the interstitium. And so fluid will leave the blood vessel. Once fluid leaves the blood vessel, you start to decrease the hydrostatic pressure because there's less fluid actually pushing against it. And you still retain all of your proteins in your bloodstream. So you still have that oncotic pressure. So what's going to happen is that toward the end of that capillary, the oncotic pressure will finally overpower the hydrostatic pressure, and you'll pull water back in. And you'll have pretty much similar concentrations intravascularly at the post-capillary venule than at the pre-capillary arterial. And the reason why this is effective is because we have so much albumin in our blood to create that oncotic pressure gradient to pull the fluid back in. And later on, when we talk about cirrhosis, if our liver is not producing enough albumin, we're going to notice that some of that fluid kind of stays out there and you might get peripheral edema. Another protein that's useful to recognize is alpha fetoprotein. This is produced by the liver, and the only thing you really need to recognize is that if it's elevated it's in an older person, that's a little concerning for HCC, hepatocellular carcinoma. And on the right box, I just added that there's multiple carrier proteins that are also produced by the liver. We go over some of these. We'll talk about Wilson's disease and hemochromatosis, so we'll go over the top two later on. But just recognize that many carrier proteins are dependent on appropriate liver function. The liver also produces coagulation factors. So it helps create all the vitamin K dependent coagulation factors, which are 2, 7, 9, 10, and protein C and S, which I highlighted on this screen to your right. And before I move on, just so we know, we'll talk about the coagulation cascade. Actually, we mentioned it in the pancreas lecture when I talked about DIC. But all you need to know is that this whole cascade, the whole point of this cascade is to form a fishnet fibrin clot. That's literally all it's for. All these enzymes and everything, all these cofactors, it's just to form a clot. So you can imagine that if you have a decrease in your clotting factors, which we'll see later, that could predispose you to bleeding. So I'll talk about that later on. I just wanted to put that thought in the mind before we talk about cirrhosis later on. The liver also produces a compound called thrombopoietin, and thrombopoietin, or TPO, is produced in the liver and the kidneys, and it can regulate platelet production by inducing megakaryocyte maturation and differentiation. So what does that even mean? Well, here is an immature megakaryocyte. So basically what's happening is our bone marrow is producing platelets all the time. It's constant turnover. Platelets do not have a long life. I could be wrong. I'm pretty sure they only live like 1 to 3 days or something ridiculously low. But basically, in our bone marrow, when we have our megakaryocytes, they're immature ones, it needs a little bit of help from the liver and the kidneys. And that help comes in the form of TPO. TPO, what it does is it'll tell these immature megakaryocytes to start growing. And so these immature megakaryocytes will grow into mature megakaryocytes. And then all these projections actually become the platelets that we see it navigating our bloodstream. It also helps to produce glucose. So that's in a few different ways. The liver can regulate this through two primary mechanisms that I'll go over. You can get it through glycogenolysis, sometimes called glycogenolysis, whatever you prefer. And that's where glycogen is lysed and converted into glucose. So you'll have these large glycogen chains, and they can get broken down into monosaccharides. Another way that we can get glucose through our liver is through the process of gluconeogenesis, which, as the name kind of suggests, is basically new sugar genesis. And that this is where non-carbohydrates like amino acids, lactate, and glycerol from fatty acids, those can actually be converted into glucose as well. So instead of talking about liver production now, let's move on to some of the things that the liver can metabolize. So as you probably know already, the liver is vital to metabolizing numerous drugs. I'm not going to go over all the different P450 enzymes, but I just wanted to point out from our previous chart on anatomy that most of these P450 enzymes live in the centrilobular zone, or zone 3. It also helps metabolize ammonia. And so ammonia is a potentially toxic byproduct of digestion. And fortunately, we have a way to convert ammonia into urea, and then urea can be excreted by the kidneys in our urine. So how does this work? Well, imagine if you have ammonia here, liver can help convert this to urea, and what I'll talk about this later in the clinical conditions section. If you have an accumulation of ammonia in your body, perhaps due to liver dysfunction, for instance, you could end up with hepatic encephalopathy. And there's the example. If your liver's not working, you can have hepatic encephalopathy. The liver also helps to metabolize estrogen, and that's through the same P450 enzymes that we discussed earlier for other drugs. It's really important for portal vein fluid as well. As you can see, all of the portal vein fluid ends up coming into the liver, so we need the liver to metabolize all that. And again, you can see it, all the portal vein fluid draining from here, the portal triad, into the central vein. And the last thing I think it's important to realize is that the liver can metabolize. It's kind of a metabolism of bilirubin, where it can help create a more soluble form of bilirubin. And recall from our previous lectures that our red blood cells are being turned over on a constant basis. They last around 3 months, I believe. And when RBCs break down, they produce unconjugated bilirubin. And that unconjugated bilirubin is water unsoluble. So if that unconjugated bilirubin tried to escape through the kidneys would just spit it back out because they wouldn't be able to filter that insoluble item. So instead, the unconjugated bilirubin makes it to the liver where it gets conjugated by UDP glucosoronyl transferase, which we'll talk about later as well. And this conjugated bilirubin is a component of our bile, and then that can eventually be secreted into our GI tract and then excreted in the feces. And here is our pictorial representation of the metabolism. So you have unconjugated bilirubin, it goes through the liver and creates conjugated bilirubin, and that's done by this bilirubin UDP glucosoronyl. So I don't even know. I'm not even going to try it. Let's just call it UGT now. Glucoronosyl transferase. Okay, we got it. So UGT is the big enzyme that's responsible for helping to create a more water-soluble compound. And how that does that, it actually adds glucuronic acids onto the hydrophobic compounds to give it a little bit more of a hydrophilic character. And because of this, once it's more hydrophilic, then it's easier to be able to mix with bile and be excreted in the GI tract. Now that we've talked about liver function, I want to discuss some of the liver function tests, some of the laboratory values that you can order to assess whether the liver is functioning well or not. And I've broken this down into a few different sections. So the first one we're going to talk about is our aminotransferases, ALT and AST. So these aminotransferases are enzymes that are found in very high quantities in hepatocytes. And because of that, if there's any damage to the hepatocytes, you will often see increased levels of ALT and AST. I put this chart here to differentiate the differences between ALT and AST. So ALT is an enzyme that often exists in the cytoplasm, whereas AST exists more so in the mitochondria. And why this matters is that if we think about a very common mitochondrial toxin, alcohol, that's going to affect AST levels more than ALT levels because it's in a higher concentration in this region. So in alcoholic liver injury, both AST and ALT are elevated because there's still damage to liver cells diffusely, but because the alcohol is more mitochondrial in nature, you're going to have a higher proportion of AST that is released. And you're going to see an AST to ALT ratio classically above 2 to 1. And the mnemonic that you'll see in a lot of your resources is this toast to alcohol. And that's to remind you that the AST is greater than 2 to 1 to ALT. And when we talk about the organs that have these enzymes, it's true that both of these enzymes exist in hepatocytes. And in the case of ALT, for testing purposes, you should assume ALT is exclusively formed in the liver. And so you can remember the ALT, the L in ALT will remind you that this enzyme is only found in the liver. On the other hand, AST has a very strong association with the liver, don't get me wrong, but you can find AST in other tissues like the heart or muscle tissue. And we'll find out why this is relevant. So when we talk about these predominant conditions, and if ALT is ever increased, you want to think about anything that can damage the liver. So a lot of causes that have hepatitis will increase your ALT. AST, I want you to think about, you can obviously think about the hepatitis. All the liver causes can cause both of these. But if you notice an AST that's rising much greater than the ALT, I first want you to think about alcoholic liver disease, like we just discussed, if you ever see that greater than 2-to-1 ratio. But they might even throw you a trick question where they give you another cause where somebody's coming in, and let's say an older lady is coming in after being found down for several hours, and her potassium's elevated and her AST is extremely high. They might, and they have an elevated CK level, they might ask you, what's going on? Why is their AST elevated? And one of the answers might be they suffered liver injury. But the real answer would probably be they actually suffered muscle tissue damage. They might be undergoing something like rhabdomyolysis, where their muscle tissue is actually dying, and that's what's causing this isolated AST increase. So just keep those in mind. But that's a little bit more less likely to be tested. That they love this AST association with alcoholic liver disease, though. So now that we've talked about the aminotransferases, I want to talk about our favorite cholestatic labs, our favorite obstructive labs that we've gone through so many times now in the pancreas and the gallbladder section. So, alk phos, GGT, direct bilirubin, they're all going to be elevated in obstructive diseases. And we went over each of these in our hepatobiliary section in great detail. So as we know, bile is created in the liver, and bile contains all of these other components to it. And all these components can ultimately drain into our gut. And if there's an obstruction, these can all leak out into our bloodstream, and we'll detect it as elevated alk phos, GGT, and C-bili. Just a reminder, again, that conjugated bilirubin is elevated in this case, this obstructed case. I just always want to remind you when unconjugated bilirubin would be elevated. And the two things you have to remember are hemolysis. So remember that unconjugated bilirubin is formed from the breakdown of RBCs. And if we're losing a ton of RBCs, what's going to happen is that you'll have a ton of a ton of unconjugated bilirubin. Sorry about the slide there. You'll have a ton of unconjugated bilirubin presence and detected in your blood studies. Liver pathologies can sometimes cause an unconjugated bilirubin, and that's because, as we talked about earlier, UGT is the enzyme that helps out to make unconjugated bilirubin more soluble. But if your liver's not working as well, you can have a little bit of a backup, and you can detect more unconjugated bilirubin. Alk phos, just as a reminder, it doesn't just exist in the liver, it also exists in the bones and kidneys. So there we just showed you that alk phos can be elevated in obstruction, no doubt, but it can also be elevated if you have some sort of bone or renal pathology. That can cause a lot of alk phos too. So if you see alk phos, don't immediately assume liver. It's good to put that on your differential, but it could also be these other two organs. Where, on the other hand, GGT is pretty much associated with liver obstruction. So GGT, if there's an obstruction, you'll get a ton of it in your blood. And this time, if you do have a bone problem, you're not going to have elevated GGT. So it's much more specific. So now we talked a little bit about this already, but I just wanted to break down what a hepatocellular pattern looks like versus a cholestatic pattern. So a hepatocellular pattern, it just means it's a pattern that you'll see on labs when the damage done is directly to the liver cells, okay? And as we saw before, ALT and AST are enzymes that exist within those liver cells. So if there's damage directly to them, it shouldn't come as a surprise that AST and ALT will both be very elevated in some sort of hepatocellular pattern. On the other hand, because there's no obstruction necessarily, the ALK phos, the GGT, and the bilirubin, even if there is some liver damage, usually most of those compounds can still escape through the bile ducts and flow through the GI tract, and you won't have significantly elevated levels. That's not always true. What you'll often see is these still will have mild elevations. It's not like they're just completely normal. There's still some elevation. But in a hepatocellular pattern where there's damage directly to hepatocytes, you're really going to see ALT and AST be elevated more than anything. What if we see an obstructive or cholestatic pattern? So this is happening because of the damage outside of the liver, but more to damage to the bile ducts or some other obstruction going on. And what's happening here, as we just saw, is that our favorite ALK phos, GGT, conjugated bilirubin, those are all elevating because they leak out into the bloodstream. They have nowhere to go. On the other hand, because the damage really isn't directly related to the liver, the ALT and AST will either be normal or just a little bit elevated. So you can see, depending on whether the aminotransferases or the obstructive liver function tests are more elevated, it can give you an idea of where the damage might actually be arising from, the liver or the bile ducts. Now let's talk about this isn't as high yield, this urine bilirubin and urobilinogen, but I wanted to be complete. So if you have time to look at this and you really want to understand LFTs in its entirety, feel free to listen. Otherwise, even for step 1 or level 1, this is probably low yield, but I wanted to mention it anyways. Urine bilirubin, what that does is it detects the amount of conjugated bilirubin in the blood. This should also make some sense. The unconjugated bilirubin doesn't make it to your urine, right? It gets kicked out by your kidneys. So it's only going to detect the amount of conjugated bilirubin in your blood. And the conditions in which you'll see urine bilirubin, you can see it in liver disease and biliary obstruction. And so let's talk about each of these conditions right now and why they would increase your urine bilirubin. In liver disease, I've talked to you many times about how you can have unconjugated hyperbilirubinemia because nothing's getting metabolized and changed into conjugated. So here's our normal pathway. We have unconjugated bilirubin. It goes to the liver. It can get conjugated. And I've told you before, oh yeah, if you don't have a good liver, then you'll get a backup of these guys here and you'll get an unconjugated bilirubin. Now, I didn't lie to you, but I didn't tell you the whole story. So yes, that can absolutely happen, where you just get liver disease causing an unconjugated hyperbilirubinemia. However, there's sometimes you have liver damage where your liver can still conjugate some of the conjugated bilirubin, but then you have so much other damage that it can't really get out of the bile ducts. And so in these cases, this can leak back out and you'll get a conjugated hyperbilirubinemia. And of course, this conjugated bilirubin can go to the kidneys and get excreted in the urine, and you'll be able to test that through the urine bilirubin. Obstruction, we've already seen this before. If you have an obstruction here in the GI, in the bile ducts, that conjugated bili will leak out along with a number of other things that we've mentioned. And of course, this can be detected in the urine as well. Urine urobilinogen is probably the lowest yield lab finding you'll ever see in your life, but sometimes on tests they're going to give you urine urobilinogen. So I want you to know what that means. All I want you to know is that urine urobilinogen is an indirect measure of how much bilirubin actually makes it into your intestines, like into your GI tract. If you can remember that, then these questions will be so easy for you. So it's going to be elevated in any condition where a lot of bilirubin is making it into your GI tract. So a common one that they'll want you to know about is hemolysis. You have so much breakdown of unconjugated bilirubin into your liver, and your liver's trying to work as fast as it can. It's conjugating all this bilirubin, and a lot of that will make it into your GI tract. And I'll go over that in a second. Where would it be negative? What conditions can you think of where bilirubin just doesn't make it into the intestines at all? Well, it should make sense that biliary obstruction would be a very common contributor to a negative urine urobilinogen level. So let's go over urine urobilinogen briefly. So the first thing that's going to happen is that conjugated bilirubin is going to make it into the GI tract. So it's in our bile and it successfully makes it into our gut. What's going to happen there is that intestinal bacteria will start to do its work on conjugated bilirubin. So it'll actually deconjugate it back to the unconjugated form. And from there, it can convert unconjugated bilirubin into urobilinogen. So now we have urobilinogen in our GI tract. Remember, we're testing the urine though, so something else has to happen here, right? So urine bilinogen has two pathways. The first pathway is that urobilinogen can be converted into a compound called stercobilin, and this is excreted in the feces. And actually, this is what gives stool its brown pigment. The second pathway that can happen is that urobilinogen can actually be reabsorbed into our body, and then this can be excreted in the urine. And this is what gives our urine our yellow pigment. So let's discuss why urine urobilinogen would be elevated in hemolysis and pretty much negative or very low in obstruction. So in hemolysis, you have a ton of unconjugated bilirubin. And if you measured the blood levels of this patient would have an unconjugated hyperbilirubinemia. But it's not like your liver's not working. Your liver's seeing all of this unconjugated bilirubin, and it's working as hard as it can. It's probably overworked, but it's doing the best it can at trying to conjugate some of those compounds, and it's trying to get rid of them too. So it's throwing all that bilirubin into your GI tract. And if you have all this bilirubin in your GI tract, some portion of it will end up be converted into urobilinogen and into your bloodstream, and subsequently into the urine, creating a high level of urine urobilinogen in hemolysis. If we look at biliary obstruction, on the other hand, if we have an obstruction here, we're not getting any of the conjugated bilirubin into our intestines in the first place. So if you don't have anything coming in the first place, you can't go through that pathway we just discussed to ultimately lead to urine urobilinogen. The last section of liver function tests I want to group together are our synthetic liver function tests. So albumin, PT-INR, and platelets. This can give us some rough idea of how well the liver is working. And let's go over this. So albumin is a pretty good indicator of hepatic protein production. Remember, we talked about albumin right here as one of the most important proteins that is produced by the liver. And it should make some sense that if your liver's not functioning as well, if you have some sort of dysfunction, then your albumin levels will decrease. PT-INR is a measure of our coagulation factors in our liver. So remember here that our liver is responsible for several coagulation factors, 2, 7, 9, 10, and then protein C and S. And when our coagulation factors start to decline, our PT-INR levels will rise. And just as it does in liver disease. And I talk about this later on when we talk about cirrhosis, but just as a heads up, PT-INR, especially INR, is our most, how do I say this? It's the most reliable indicator of liver dysfunction, even more so than albumin. It's more accurate. And if you have acute liver injury, which can happen, because factor 7 is injured most on this. Let me go back to this. Because factor 7 is the quickest, it has the shortest half-life. If your liver's not working and you're not producing any factor 7, then your extrinsic pathway will be damaged, and that'll cause an elevated PT-INR. That'll be the first thing you can notice on laboratory findings in to assess for synthetic liver dysfunction. And so let me move on to platelets now. So platelets, remember, part of the platelet process is that you need that thrombopoietin signal from either the liver or the kidneys for your immature megakaryocytes to start to mature and differentiate. And we have it right here that if you, oh, that's all I show right now. I talk about all this stuff later. Sorry about that. But all you need to know here is that this TPO is really important for maturation and ultimately platelet production. So it should make sense that if you don't have any TPO, then you might have thrombocytopenia. And that's why the platelet count decreases in liver disease. There's multiple pathways, but by which you get thrombocytopenia in liver disease. Just a heads up, it's not just this. Like for instance, we'll talk about portal hypertension later. If you have a bunch of fluid stuck in your portal system, a lot of that can back up into your spleen, and then your spleen can just basically eat up all your platelets or just kind of keep them sequestered in your spleen. So then you get that's another reason for thrombocytopenia. So don't take this as the only reason, but what I want you to know on this slide for now, I'm kind of rambling. I just want you to know that albumin, PT-INR, and platelets are all lab tests that are useful for you to determine whether your liver is working well or whether it might be a little dysfunctional. So that covers the liver function tests and the entire physiology section. Now we're going to go to the liver condition section. The first one I wanted to talk about is cirrhosis because I think it ties in so well to the physiology we just talked about before. The pathogenesis of cirrhosis is that you'll get liver damage. That liver damage will activate our stellate cells. Those stellate cells will secrete TGF-beta, and that TGF-beta can potentially lead to fibrosis, and that fibrosis, if you have too much fibrosis, it'll turn into cirrhosis. So again, you have inflammation, stellate cells are activated, TGF-beta is released, that causes fibrosis, and if you have too much fibrosis, that'll in turn lead to cirrhosis. There are several causes of cirrhosis. This doesn't even probably doesn't even include a third of what can cause cirrhosis. We're going to go over most of these today, though. Alcohol, non-alcohol fatty liver disease, hepatitis, biliary disease, genetic syndromes, congestive liver disease that we talked about earlier. These can all cause cirrhosis. And then actually I'll go back to what we talked about earlier in our anatomy blood supply section. You can see that if our hepatic vein has a clot in it in Chiari syndrome, or if our right heart's just not working as well as it needs to, you're going to get congestion back in the liver, and that can cause cirrhosis. Here are all the symptoms of cirrhosis, and a lot of textbooks will just give it to you, just say, hey, here's all the symptoms, like just memorize this. I just wanted to include this just so you see it, and what I'm going to do is for every single section we talk about, you'll see one of these symptoms pop up, and I'll explain it in great detail just so you're not memorizing random stuff, and because I want it to all make sense to you. This is from our physiology section we just talked about. We talked about all the different functions that the liver has by way of production and metabolism. The nice thing is what I'm going to do for liver cirrhosis is I'm going to talk about what happens when each of these 10 things goes wrong. So now that we have liver dysfunction, we can assume that our production of those 5 compounds on the right is not going to be as efficient. And we could also assume that the metabolism of all 5 of these compounds on the, I think I said on the right here, on the left, the production of all these compounds on the left, if anything goes wrong there, we'll see what happens. And then we'll also see what happens if any of these compounds on the right cannot be appropriately metabolized. So let's start with production. I'm going to make a little table for all 5 compounds that I want you to know the liver is producing and what happens when things go wrong. So if bile's not getting produced, the thing I want you to remember first is fat malabsorption. And we've talked about this in the pancreas and in the small intestine lectures and in the gallbladder lecture, actually, that bile is important for fat digestion. And that works because lipids are amphipathic, which means they have a hydrophilic and a hydrophobic region. Here's our hydrophilic region. Here's our hydrophobic region. And I'll show what a fat globule will look like in your GI tract. We have our hydrophilic region kind of surrounding the barrier and encountering the watery environment, whereas all the hydrophobic chains are kind of hiding in the middle. And when lipases try to come in here, they really want this juicy thing in the middle, but they can't really get it as easily. The good thing is that bile is amphipathic, so bile can actually come in here and it'll convince these globules to kind of split up into several smaller globules because the bile is emulsifying it. And in this way, the pancreatic proteases have a much easier time with achieving more enzymatic breakdown and more surface area. And so that's what happens. The problem is in liver cirrhosis, if we're not producing any of this bile, then these globules don't get emulsified and they stay big and you get fat malabsorption. If the liver doesn't produce adequate proteins, there's many, many, many things that can go wrong. But 2 main symptoms that I'll talk about are peripheral edema and ascites. And in the physiology section, I talked about how there's 2 competing forces. We have our hydrostatic pressure that pushes fluid out of the intravascular space, and we have our oncotic pressure that helps pull fluid back into our blood vessels. So initially, usually the hydrostatic pressure will force fluid out into the interstitium, but because the hydrostatic pressure decreases and our proteins stay in and our oncotic pressure will increase relative to the hydrostatic pressure, the fluid will get pulled back in and everybody's happy. The problem is that in liver cirrhosis, we don't have enough albumin to start. And so we're losing a lot of that oncotic pressure. So the first thing that still happens is that the hydrostatic pressure will push that fluid out. But then as we get back down to the post-capillary venule, we have a very low oncotic pressure. And so there's no driving force to pull that fluid back in. And so that fluid will stay in the interstitium and you'll end up with edema. Ascites, I just want to point out ascites is extremely important, but I'm going to talk about it later when I talk about portal hypertension. So it's coming very soon. I just wanted to mention that I talk about it there instead. Coagulation factors. So because the liver is responsible for coagulation factors, there's a theoretical risk of bleeding. And I'll show you. So the PTT, we've talked about this in previous lectures, but the PTT measures this intrinsic pathway, so all of these guys here. And the mnemonic is you play table tennis inside, so that's how you remember PTT, whereas the PT measures the extrinsic pathway, and you play tennis outside, so that's a good way to remember that tennis is for extrinsic. Factor 7, as I mentioned before, has the shortest half-life, and so it's the one that's deranged first in liver disease, and that's why PT-INR is the most useful test of synthetic liver function. Thrombopoietin is important for liver production, and it shouldn't surprise you that thrombocytopenia would be a side effect of liver cirrhosis. So if you have no thrombopoietin, you don't get mature megakaryocytes and you don't get platelets. Glucose is not, if glucose is not actively produced or metabolized, you'll get hypoglycemia. So remember here from our liver function discussion that glucose can be glycogen can be converted into glucose as well as non-carbohydrate substances. And the liver is great at performing each of these processes. But if your liver's not working, you might not get so many monosaccharides floating through your bloodstream and you become hypoglycemic. Okay, so now let's talk about metabolism. So what goes wrong? If you can't metabolize certain products, what are going to be the end result? So if you can't metabolize drugs, it should be obvious that you can get drug toxicities, and this is common in liver disease. Maybe not common, but it's a known effect of liver disease. And that's why you have like dose reductions for people who have liver or kidney disease. The whole point of that is that you want to make sure that they're not going to have toxic levels of it based on the amount that they'll be able to excrete compared to a normal person. Ammonia is metabolized by the liver, and if you can't process ammonia correctly, you can get hepatic encephalopathy and asterixis. So recall from the physiology section we talked about earlier that if our liver's not working, we're going to have a buildup of ammonia, and that can result in hepatic encephalopathy. I'm kind of breezing by hepatic encephalopathy because I do talk about it in the conditions section where I compare hepatic encephalopathy, and I also talk about Rye syndrome. So keep that in mind. That'll come up later. You can learn all about asterixis, and which is like a bird flapping tremor. We talk about that in a little bit as well. Estrogen is important. The liver is an important organ to metabolize estrogen, and if that's dysfunctional, you're going to have excess estrogen in your system, and that'll show up in many different ways. You can get testicular atrophy, you can get gynecomastia, amenorrhea, spider angiomas, and palmar erythema. All of these are due to excessive estrogen levels, and something they love to test. What they'll do is they'll give you a picture like this. And somebody who sounds like they have liver cirrhosis, this is the spider angioma, or they'll give you somebody with red hands, reddening of the hands. And what they'll do is they'll say the mechanism of action for this skin condition or this condition is most similar to the mechanism of what other symptom. And then they'll want you to pick, if I go back here, they'll show you a picture of like a spider angioma or pulmonary erythema, and they'll ask you that question. And they'll want you to pick like testicular atrophy or gynecomastia or amenorrhea. So I hope that makes sense. This is very commonly tested. They'll give you a spider angioma and they'll say, what's the problem with it? Or they'll say, what's driving this? And the answer would be estrogen. Or they'll say, what other symptom can be caused by this? So keep that in mind. Very, very high yield association that they love to test on. Okay, now we get to the fun part where we talk about portal vein fluid. So if you cannot adequately metabolize all that or process all that portal venous fluid that's coming into the liver, you're going to get portal hypertension, you're going to get Porto-Systemic Anastomoses, which I'll talk about in a little bit, and you'll get ascites. So here's where I want to delve deep into all of these contributors and talk about what goes on. So portal hypertension, as the name suggests, is increased portal venous system pressure. This can be caused by liver cirrhosis or vascular obstruction. So we'll talk in liver cirrhosis, if your liver's not working well at all, then you're just not going to be able to process all that portal fluid and it'll all back up. And so that's how you get portal venous congestion and hypertension. In vascular obstruction, even though the obstruction happens a little bit more, I guess, distal in the pathway, so right heart failure would be here, you'll have everything raised, including your portal vein. And in Chiari syndrome, you'll have a clot in your hepatic vein. And again, your portal vein will ultimately be congested and have higher pressures. And in portal vein thrombosis, same thing. If you have a thrombosis, you're going to have back pressure causing portal hypertension. So the complications of portal hypertension, you can get splenomegaly. And what's happening here is that as that portal vein fluid flows in the liver, if there's ever a problem with that flow, you'll get a backflow, and it can actually reverse the flow and end up leading to congestive splenomegaly as well. This can also increase the risk of splenic vein thrombosis. So you can actually have a thrombosis in this vein. And I'm going to kind of quiz you right now as far as the most common cause of splenic vein thrombosis. We talked about it in the pancreas lecture. It's actually chronic pancreatitis. You can have a lot of inflammation in this region right here, can predispose people with chronic pancreatitis to splenic vein thrombosis. Some other complications, ascites is a big complication of portal hypertension, as well as Porto-Systemic Anastomoses. I'm going to discuss these within the next couple minutes, so keep those in mind. Before I do that, though, I just want to talk about what a TIPS procedure is, because this is a treatment that can be occasionally used for people with really bad portal hypertension, symptomatic with ascites or varices. You want to at least consider a TIPS procedure, which is a transjugular intrahepatic portosystemic shunt. So what did I just say? What the heck is TIPS? So what it is if your liver's not working well, we're going to have a ton of portal fluid, and that can drain out and cause a bunch of problems, right? If we want to fix this, what we can do is, instead of trying to go through this really, really crappy liver, maybe we can consider bypassing the liver, right? And so that's what a TIPS does. It actually is a shunt between your portal vein and your hepatic vein. So it's a portosystemic shunt, portosystemic shunt. And this seems great, right? Look at that. We just relieved our ascites and our edema. We have no more portal hypertension. Our risk of rupturing esophageal varices is less. Wonderful, right? Well, the problem with it is that it can precipitate hepatic encephalopathy. Remember, we just talked about how important the liver was in converting ammonia into urea for excretion. So we have our ammonia and it gets converted into urea. If we completely bypass the liver, then all that ammonia is just going to stay in our system. And so that can cause a really, really dangerous problem sometimes. So we've talked about portal hypertension. So now let's talk about some of the other sequelae of excessive portal vein fluid. So we're going to start talking about all of our porto-systemic anastomoses. So I've shown you this diagram so many times, you're probably sick of it, but we have our portal vein, drains into our liver, out the hepatic vein, and into our IVC. Keep in mind that in just a normal blood vessel that's not our portal system, we have our arteries. Those arteries go to arterioles and then capillaries. The capillaries drain into venules and then into veins. And then ultimately it'll go back into the SVC or IVC, depending on where you are. We'll notice how they both connect in the IVC. And so I'm just going to simplify this. We have our portal vein, ultimately goes into our IVC, and you have just a standard vein, ultimately also going into the IVC. What can happen is that if the portal vein becomes really enlarged and congested, there's a few areas in our body that are connected to our systemic circulation. So they actually have a connection naturally. And if this gets really, really big and has a lot of back pressure, it can actually cause higher pressures and congestion into our systemic circulation. So that's why it's called Porto-Systemic Anastomoses. So there's three places in our body that you need to understand have these anastomotic connections that are clinically relevant. We can get esophageal varices, which occur with a connection between our left gastric vein, which is part of our portal system, and our esophageal veins, which is part of our systemic circulation. You can also get something called caput medusae, which means like Medusa's head. And that's from our para-umbilical portal veins connecting with our epigastric veins. The last condition I want you to know about are anorectal varices, and that's where our superior rectal vein has a connection and provides back pressure to our inferior or middle rectal veins. So let's talk about each of these three. The mnemonic that I think I saw in first aid, I want to give, this is not my mnemonic. It was, oh no, I wrote it down. UWorld, I guess, has this. Actually, no, I think it's first aid. I think I mistyped. Anyways, the mnemonic is you can get varices of the gut, butt, and caput. So here's your varices of the butt, your anorectal varices. You can also get it of the gut, your esophageal varices, and then you have caput. Let's start by talking about esophageal varices. So I'm going to use our chart that we just have. We have our left gastric vein. So imagine our left gastric vein, which you can see in the diagram here, is this vein here. Imagine this gets congested with because of portal hypertension. What can happen is that it actually has a little bit of a connection to the esophageal vein right here. And what's relevant about that is that our esophageal veins are not built to withstand high pressures. And the problem is that with these high pressures, it can actually rupture and cause a very brisk upper GI bleed that can be life-threatening. And here you can see an esophageal varix on the right. This slide was taken from the esophagus lecture where we talk about esophageal varices in great detail. And I just wanted to point out that the main pathogenesis involves portal hypertension, which is why we see it in this section. You can see that these varices can rupture because that esophageal vein is not built for that kind of pressure, and that can cause hematemesis. You can get bloody throw up. You can get bloody stools as well. Kaput is a lower yield, but still relevant to know. Using our chart again, we can see here, we have our para-umbilical vein right here. So if this gets congested, you can see that it's connected to our epigastric veins right by our belly button. And so this can actually leak out and you can see very profound, you'll be able to see these epigastric veins if you see somebody's stomach who has this. And it'll look like this. You can see it's called Medusa's head because it's got this very tortuous snake-like appearance of these engorged epigastric veins from our systemic circulation. Anorectal varices are also worth noting. You can see right here, here's our superior rectal vein draining into our portal system. And so if we have a backup of all that superior rectal vein, it can anastomose with our inferior rectal vein right here, and that can cause hemorrhoids. So you'll get some bleeding in this area. Now let's discuss ascites, which are a common side effect of portal hypertension. So ascites is just the fluid accumulation within your peritoneal cavity. And so what that would look like is if we have our picture here, that's just this whole cavity here. Just imagine that starting to get filled with peritoneal, with fluid essentially. This can be caused by a few different things. The most likely being portal hypertension. So most of the time, if you see ascites, it's portal hypertension. However, it can still be related to some pretty dangerous things. It can be related to malignancies, tuberculosis, and pancreatitis, among other things. And a question that's worth asking is, how do we tell? Is it portal hypertension? Is it a little bit more of a dangerous cause? We can use a lab test called the serum ascites albumin gradient, or the SAAG, to differentiate between portal hypertension and other causes. So how do you calculate a SAAG? So what you're going to do is you'll take a blood sample to get their serum albumin. You can see how that you need the serum albumin. You're going to first take a blood test, and then you're also going to do a paracentesis, which is where you just poke a needle into somebody's belly and drain out some of that acidic fluid. And you can also then have the albumin level tested of the ascites. So you're gonna collect the serum albumin and the ascites albumin, and then you'll minus them. So as an example, let's say your serum albumin's 4 and your ascites albumin's 2.5. That would give you a SAAG of 1.5. And how do you interpret these results? If it's ever 1.1 or above, then it's probably related to portal hypertension. And if it's less than 1.1, it's more likely to be another cause. Sometimes you'll forget, especially if you're studying late, like if you haven't looked at this in a while. So my mnemonic I like to use to remember, oh shoot, is it above 1.1 or below? I just remember that hypertension is always, we always think of hypertension as high blood pressure. So then that helps me remember, okay, high, the greater than value is going to correspond to the hypertension cause. So I just gave you a bunch of numbers and just basically told you to like remember that, but that's not helpful. So let's actually go through Why is the SAAG greater than 1.1 in portal hypertension and less than 1.1 in other causes? So if we have our portal vein here and our peritoneum, if we have fluid in our portal vein, that's great, but then if it leaks out, now we have ascites. Remember, just like in any other blood vessel, our portal vein is going to be filled with some amount of proteins, mostly albumin. And in let's start by talking about portal hypertension. In portal hypertension, what's happening is that we have so much fluid within this limited space that you're going to just naturally just squeeze out some more fluid to the outside, just because there's so much hydrostatic pressure that some of that fluid will just inevitably escape into the peritoneal cavity. With that, just a very, very, very small amount of albumin will also escape, but nothing like the amount that we'll see in other conditions. And so then if we calculate the serum albumin here, let's just say our serum albumin is still 4, and let's say, a decent amount escapes into the acidic fluid, but not too much albumin. Then if we calculate the SAAG, it'd be something, for example, 4 minus 2, and that would still give us a SAAG of 2. And remember here that if anything greater than 1.1, likely related to portal hypertension. And it's because not too much albumin is escaping. It's a lot more of just the fluid escaping because of that strong hydrostatic force. What if there's another cause, though? So in another cause, let's just say that we don't necessarily have portal hypertension, but let's just say we have some malignancy or some infection like TB, or we have pancreatitis, and it's just damaging the entire wall of our epithelium. It's damaging our portal vein directly. So what happens here is that there's no hydrostatic pressure that's like preferentially throwing out a little bit of fluid and maybe, a lot of fluid and some albumin. In this case, it's anything goes. If your epithelia is damaged here, anything can escape into your peritoneal cavity, including albumin. So in this case, a lot more, you're going to have a higher number for your ascites albumin level. And so if you calculate the SAAG, you might get something like 0.5, which again, since that's less than 1.1 now, you're going to have a strong suspicion for these other causes of ascites instead of portal hypertension. So to treat ascites, you can give them paracentesis. A lot of people will come in every few weeks to just get a therapeutic paracentesis, where they'll have a certain number of liters of fluid removed so that they can, breathe better and function better. You should often give them diuretics and restrict their diet, kind of like you do with heart failure as well. You can also give spironolactone. You'll notice a lot of people are on spironolactone as well as furosemide, very common. And like we talked about in the portal hypertension section, you can do a TIPS procedure. And this is, if your liver's not working, you'll get a backflow of fluid to get ascites. But if you have that shunt between the portal vein and the hepatic vein, then you won't have as much backflow and you'll reduce your ascites. But as we talked about before, remember that this can precipitate hepatic encephalopathy. So you don't use this in every patient with ascites. One important complication I want to discuss here is SBP, spontaneous bacterial peritonitis. And so what this is actually an infection of your acidic fluid. And it's usually caused by some bacteria that's already in your gut that migrate into the acidic fluid, such as E. coli or Klebsiella. And believe it or not, the majority of these cases are asymptomatic, but you can get fevers, chills, or abdominal pain. And so anytime a known person with liver cirrhosis comes in with a fever, chills, or abdominal pain, you need to have a high index of suspicion for SBP. And you can diagnose it by, like I said before, you can do a paracentesis where you just drain out a bunch of that fluid. But you can also do a diagnostic paracentesis where you take some of that fluid, send it out for lab cultures to see how many cells are growing in that culture. And a really, really high yield number that you need to remember for boards, definitely remember this, is that if you ever have an absolute neutrophil count of greater than 250 cells in your acidic fluid, that's diagnostic for SBP. Something, maybe this is more helpful on the wards. They'll give you, when you look at Ascites fluid cytology, it doesn't give you the ANC directly. It'll give you like the total white cells. It'll be like, let's say it has 1,000 white cells, and then it'll say like 4% neutrophils. So then if you just looked at the white cell count, you might think, oh, nice, this person has SBP. I just diagnosed it. But in reality, only 4% of those white cells were actually neutrophils. So the absolute neutrophil count in my example would be what, 4% times 10, so 40. So you'd have an ANC of 40 in that specific example, and that would not meet diagnostic criteria for SBP. Again, they're not going to test you on that. That's kind of just like a little word pearl for you. Just keep that in mind. And you got to treat this with antibiotics, and you want to cover things that will basically make sure to cover your gut flora. So stuff like ceftriaxone. Oftentimes people will also add on like metronidazole in that case to cover for anaerobic infection too. Okay, so that covers portal venous fluid. Let's talk about what happens when bilirubin metabolism gets a little bit messed up. So some of the symptoms that you'll see in liver cirrhosis that have to do with inadequate bilirubin metabolism are hyperbilirubinemia, jaundice, and gallstones. So hyperbilirubinemia and jaundice should make sense. You can get, as we've seen so many times now, RBCs are broken down into U-bili. That U-bili gets conjugated. But if you don't have a good liver, you can easily have an elevated unconjugated bilirubin. At the same time, you can, if your liver is damaged in the more distal part of this process, you might still get bilirubin conjugation, but it can't get excreted. So then you'll get elevated conjugated bilirubin. So either one of these can still be true. You might have a conjugated, you might have unconjugated, you might have a mix, but you're going to see some sort of hyperbilirubinemia oftentimes in liver disease. And then just as a side note, anytime you have either conjugated or unconjugated bilirubin in your bloodstream, it'll give you jaundice. Gallstones are also possible in liver disease. This is from our hepatobiliary lecture where I talk extensively about gallstones. And I just want to remind you that bilirubin is a component of gallstones. And if you have elevated levels of bilirubin, or if you have the more insoluble subtype, like unconjugated bilirubin inside of bile, you're more likely to get gallstones. There's two types of bilirubin gallstones that you had to remember. The black pigment stones are for hemolysis and brown are for infections, and I have some good mnemonics there. And what I mentioned kind of in passing in the hepatobiliary lecture is that because you have impaired bilirubin conjugation, you could also get bilirubin gallstones. So if we go to the picture, if we have unconjugated bilirubin, the problem is that some of it won't get completely conjugated before it reaches the bile ducts because you have a little bit of liver disease. And my whole thing of how you get bilirubin gallstones is I tell you that you only get bilirubin gallstones when you have unconjugated. You have this like stone-like mass. And so that's kind of the mechanism by which people with liver cirrhosis are predisposed to gallstones, especially bilirubin gallstones in that case. One of the last things I want to talk about with cirrhosis is how it's diagnosed and how you stratify risk. The diagnosis, as with most things, the gold standard is a biopsy, but you can often just diagnose liver cirrhosis clinically. There's a few different scales that are used to stratify risk of people who have liver disease. There's the Child-Pugh class score and the MELD score. This wasn't emphasized on many of the resources. I know Boards and Beyond talked about it. I don't remember if many of the other resources talked about it. And I don't recall seeing it in step 1 or level 1, but it's been a while. I'm still going to tell you about them because that's what I do. I just give you way too much information. But I hope it can be useful for you, especially on wards. So the Child-Pugh risk stratifier uses 5 variables. And the nice thing about these is that these variables intuitively should make sense to you. We already know our bilirubin will be high in liver disease, our albumin might be low, our INR might increase because we don't have factor 7 working. We might have ascites and we might get encephalopathy. So it actually scores each of these from 1 to 3, and then you rate it. So 3 being the worst. And you calculate all 5 things up, and the higher score is the worst outcome. So a score of 5 to 6 is Child-Pugh class A, 7 to 9 is class B, and then 10 to 15 is class C, which is the worst of the Child-Pugh scores. The MELD score uses only 3 to 4 variables, so it still uses bilirubin and INR. It actually uses creatinine and sodium as, well, sodium sometimes as markers, and I'll talk a little bit about hepatorenal syndrome in a second to show why creatinine can sometimes be a useful marker of end-stage liver disease. The scores here are from 6 to 40, and a higher MELD score will indicate a higher estimated 3-month mortality. The treatment for liver cirrhosis, you usually give diuretics, and you have to treat the complications. And some of those complications we've already talked about. We've talked about pretty much everything I've talked about already is technically a complication, right? Like some sort of symptom of cirrhosis. We talked about ascites and SPP as well. You can get variceal hemorrhage from those esophageal varices, those anal rectal varices. You can get hepatocellular carcinoma. This is something I haven't really emphasized too much to you guys, but anytime you have chronic inflammation in your liver and you have cirrhosis, that's going to predispose you to HCC. And oftentimes we screen anybody who has liver cirrhosis should receive a screening liver ultrasound every 6 to 12 months to make sure there's no concerning masses. I talk about hepatocellular carcinoma coming up later in the condition section, but just keep that in mind. Very high yield cirrhosis and its association with HCC. The last complication I want to talk about is hepatorenal syndrome. This for sure will, I don't know, maybe not for sure. I'd be shocked if you got a hepatorenal syndrome question for step 1 or level 1, but I want to teach you it because I don't know. I just want to teach this, I guess. So hepatorenal syndrome, life-threatening kidney failure due to liver cirrhosis. So what's happening here? This is kind of my Cliff Notes version of it. Basically, when you have liver cirrhosis, you can't metabolize nitric oxide, and your liver also produces some nitric oxide. So you get way higher levels of nitric oxide in people with liver cirrhosis, and nitric oxide causes vasodilation. So your blood vessels get very dilated. And the problem with that is that if your blood vessels get very dilated, it actually pools blood in other regions of the body, and your kidneys will sense less blood flow to the kidneys. In addition to that, keep in mind that these people who have liver cirrhosis like this, they already have a lot of peripheral edema. So a lot of their fluid that we want to keep in their blood vessels, a lot of it's already escaping. So not only are we having lack of blood flow in our intravascular space initially, now we have this massive vasodilation. That's really going to restrict our kidneys' perception of how much blood flow it can get. Now, normally, if our kidneys are sensing low blood flow, let's say I'm like dehydrated or something, right? My kidneys will constrict. My kidneys will send stuff and they'll constrict all the blood vessels, and life will be maybe not great, but our kidneys can compensate. And so we're going to activate our renin angiotensin aldosterone system, and that'll cause renal vasoconstriction, just like this. There's a problem though. So normally, if this was my kidney, this would probably work. My kidneys would secrete these hormones, my vessels would constrict, and I'd have some compensatory blood flow to the kidneys until I hydrated myself, for instance. The problem with liver cirrhosis is that there's so much nitric oxide in our body causing this massive vasodilation that even if your RAS system is activated, you're still going to remain vasodilated because of that nitric oxide. And so what's going to happen is that your kidneys will keep constricting and constricting and constricting, just hoping that that's going to be a helpful factor to give up more blood flow temporarily. But the problem is over time, your kidneys are just going to constrict on themselves and they'll start to die off because they're just going to hypoperfuse.